Professor Gambaro for this elegant talk. As we said, any question discussion will be after the session, immediately. And now, on the WhatsApp number on the screen. Now our next guest speaker is Professor Mohsen Elkossi. Mohsen actually is graduated from Egypt, Asyut University. Asyut, yeah, and he has a long journey in the UK. He's now living there, and he works in Doncaster, in near Sheffield, actually, in the nearly middle of England, or a little bit to the north.
South Yorkshire.
South Yorkshire, right. Professor Mohsen will be talking about metabolic acidosis in CKD, right.
Thank you very much for this introduction, and thank you for the kind invitation. And I would like to congratulate the organizing committee about the recognition of this meeting as a part of the European Renal Association. And to be honest, I have to admit, I will just gain the record of these 12 points for my personal CBD. And I need the certificate, please. Can I just have the lecture, please? Just if you can just... until we just prepare this, you can just do this one. It is here. This one. If you can just transfer it. You could just put it on your computer, would be better. Here it is. Clearly, I mean, what I'm going to talk is not to talk about the difference between acute and chronic metabolic acidosis. This is beyond the scope of this talk. I'm not going to discuss amine gap metabolic acidosis, or hyperchloremic and normal amine gap metabolic acidosis. This is again out of the scope. This is again out of the scope of this talk. What I'm going to discuss, it is the implications of the metabolic acidosis in the context of the chronic kidney disease. If there is any evidence at all that the treatment or intervention of metabolic acidosis in these circumstances will make any difference in terms of the progression of the chronic kidney disease, slowing or not doing anything. And the second point is, if there is any evidence to start with that metabolic acidosis in this context can make any alteration in the course of the metabolic acidosis and the chronic kidney disease or not. Clearly, why metabolic acidosis in particular? Following the era of the RAS inhibition and the antiproteinuric effect and the slowing the progression of the chronic kidney disease, nephrologists didn't gain any that much of the progress in the area of the progression of the chronic kidney disease. We haven't achieved any much so far, to be honest. Apart from the classic, modifiable risk factors of blood pressure control, proteinuria control, glycemic control, we don't have that much substantial progress in the process of the chronic kidney disease progression. To the point that I was surprised that I can see around 2.5 million patients across the world in the low economic areas are denied renal replacement therapy because of the financial constraints, which is very strange. It's okay, it's fine. So, this is very, very astonishing. There are a lot of trials in all directions in terms of, say, for example, metformin and antifibrotic effect, pentoxifylline and antifibrotic effect, allopurinol, and the SGLT2 receptor inhibitors, and we are waiting the results of the Credence trial. Hopefully in 2 days' time will be discussed in the ISN, the results of this trial, which will be a breakthrough in the management of chronic kidney disease in diabetic patients and the antiproteinuric effect. So probably the metabolic acidosis is part of this dilemma. And there was a renewed interest of the metabolic acidosis within the last decade. And where the evidence is, do we have any evidence to suggest or support the idea of the metabolic acidosis in slowing the progression of the chronic kidney disease, this is what we are going to see now. Thank you very much. That's fine. So what is the prevalence? We all know that, I mean, the metabolic acidosis is prevalent on those patients with advanced chronic kidney disease, particularly CKD stage 3, 4, and 5. In stage 5, there are some records to say that around 50% of those patients have got some element of chronic metabolic acidosis. What is the impact of the chronic metabolic acidosis? Plenty. We know, all of us, that cause muscle wasting, cause, bone resorption, stunted growth, inhibition of the, resistance to the insulin, and inhibition of the insulin growth factor 1. But the most important one is this one, which is the acceleration, slowing the progression, the acceleration of the progression of the chronic kidney disease, which is the main focus of this talk. Do we have an evidence? Yes. On the experimental level, all the subtotal nephrectomy rat models of chronic kidney disease, whether the 5/6 or 2/3, confirmed that chronic metabolic acidosis accelerates the progression of the chronic kidney disease, except only one study in 1995 by a group in Sheffield called someone called David Russell, who denied the impact of the chronic metabolic acidosis in chronic kidney disease progression. And there is another study suggested that the subtotal nephrectomy rat fed with some phosphate high diet can be protective against the progression of the chronic kidney disease. But this was not reproduced in another studies. So all of the studies suggest that definitely the chronic metabolic acidosis accelerate the progression of the chronic kidney disease, and the mechanism is through endothelin production, excessive endothelin production, angiotensin 2, and the ammoniogenesis with the complement activation, with the profibrotic effect, and the aldosterone as well. What about on the level of the human being and the clinical evidence? The MDRD study has examined, 1,780 patients with CKD at different stages, with the eGFR median was around 39 mL per minute. And they found that those patients with low serum bicarb is associated, thank you very much, is associated with the risk of kidney failure and mortality. As we can see here, the outcome was the kidney failure or composite endpoint of all-cause mortality or kidney failure and all-cause mortality. And you can see here that there is definitely an increased risk of around 2.2 hazard ratio, 100% increase on those patients with a bicarbonate level less than 22 millimole per liter, compared to the quartile of bicarbonate more than 25 millimole per liter, have got the kidney failure. And all-cause mortality is around the hazard ratio is around 1.39, which is around 40% increase compared to the general, to the other quartile. This, the previous study was in the multi-ethnic group study in the United States. And what about the European ones? This is the French group who examined the 5,400 patients for 3.4 years, and they found the same results. And they found that the hazard ratio of the kidney failure around 1.5 on those patients with the bicarb level less than 22 millimole per liter. This is the clear evidence of the quartiles of the bicarbonate level amongst the different groups. And you can see the graph of the association between the hazard ratio and the bicarbonate level. And it is a U-shaped graph to our surprise. And you can see that those with the bicarb level more than 25 and 26 millimole per liter has got increased risk still of hospitalization, mortality, and renal failure for unclear reason as yet. It's not explained. This is the mechanism that we have discussed, how the metabolic acidosis or chronic metabolic acidosis can induce the progression of the chronic kidney disease. If this is the level of the chronic kidney disease at the different stages, what about the metabolic acidosis in the context of early CKD? CKD stage 1 and 2, with the eGFR more than 60 mL per minute, they found the same results. So a 5,000 patient has been examined, and they looked into the drop of the eGFR by around 5% or more than 5% per year, and they found the hazard ratio for those patients with bicarb level less than 21 milliequivalent per liter, 1.35 or 1.4, which is again the same. As you can see, those patients with the low bicarb level has got higher hazard ratio of developing a rapid progression of the chronic kidney disease. So it is not only advanced stages of CKD, it is also early stages of CKD with metabolic acidosis can induce the rapid progression of the CKD. Is it that the level of the chronic kidney disease only, or those on dialysis and transplant has got the same problem? This is again the same study about those patients with the eGFR more than 60 mL. And again, it is U-shaped, the same finding. On dialysis, the same finding. Those patients with the bicarb level less than 19 milliequivalent per liter showed higher mortality, and more important than higher mortality, higher hospitalization compared to those patients with the bicarb level of around 22 or 23, which is very interesting, to be honest. And the only difference between the dialysis group and the CKD group, not yet dialyzed, is the movement of the curve to be starting from around bicarb less than at around 16 and 17, not at the 22, which is normal for the CKD. So we can see the hazard ratio is around 1.4 at this stage. So the evidence again is reproduced as regards the mortality and the hospitalization, and it is U-shaped with the bicarb level more than 26 or 27 has got the same problem of increased mortality and increased hospitalization. What about the transplantation? The same problem. In the transplantation, we found that the metabolic acidosis is common, particularly in the first 3 months post-transplantation, and those patients with the bicarb level less than 21 milliequivalent per liter are prone to early graft failure and mortality. As you can see, those patients with the bicarb level less than 21 millimole compared to the normal and the high bicarb level, this is the graft failure, and this is the mortality. This all the clinical evidence of that chronic metabolic acidosis in different stages of chronic kidney disease can cause progression of the chronic kidney disease. But this is all theoretical. And what about the intervention? Do you think that if we are intervening here and correcting the metabolic acidosis is going to do any positive impact in slowing the progression of chronic kidney disease or not? This is what will be answered in the next part. So the first randomized control trial was around 2009 by a group in London, when they have randomized around 134 patients with the CKD at different stages between eGFR 15 to 30, with a bicarb level of 16 to 20. And they found positive results, to be honest. As you can see, here they have achieved what they are looking for by correcting the metabolic acidosis. And at the end of the trial, after 2 years, you can see clearly that the treatment arm or intervention arm has got normal bicarb compared to the placebo arm. And you can see that the outcome, the progression or eGFR drop in the treatment arm was around 1.8 ml per minute per year in the intervention group versus 5.9 ml per minute in the placebo group, which is very interesting, to be honest. And the rapid progressors was around 45% in the placebo versus 9% in the treatment group. And again, the end-stage renal disease and requirement of dialysis was 33% versus 6%. Very interesting. And the nutritional parameters has improved significantly in the treatment arm. And as you can see here, around 33% versus 6% for those patients requiring dialysis after 2 years from the treatment with the sodium bicarb. But we have got a problem with the old correction of the chronic metabolic acidosis because of the sodium. Giving sodium in a patient with CKD stage 4 or 5, we are very concerned about the salt and water retention, fluid overload, heart failure, hospitalization. Do you think that in this trial there were any of these problems? This is the outcome. There was no statistical difference between both groups, whether the treatment arm or the placebo group. But to me, to be honest, if you can look into that, although it is not statistically significant, but clinically significant, you can see those patients who are having the sodium bicarb has got definitely more worsening of the hypertension and more worsening of the heart failure, although it is not statistically significant. Right, okay. So what about the CKD, again, in the same group, but with the better bicarb level at baseline? Not the 16 to 20, it is 20 to 24. And they have just tried it in around 20 participants in CKD4 to see what is the impact on the physical activity. And they found the same result. Correction of the metabolic acidosis around 20 millimole per mole. You can see that the 5 repetitions or 10 repetitions of the sit to stand physical activity definitely better in the treatment group compared to the placebo group. What about the intervention in patients with not normal kidney function, CKD, early CKD stages, CKD stage 2, with the eGFR more than 60 mL per minute? Again, you can see the average for this group was around 75 mL per minute, and it showed the same response. The drop of the eGFR was definitely better amongst the sodium bicarb group versus the placebo group. But the number of patients, as you can see, very limited, and I'm not sure about the power of this study, whether this is, clearly has got a meaningful result or not. As you can see, the difference very clear for the intervention group compared to the placebo group. Finally, they have done the same thing with the same group. They have tried it in 124 patients versus 93 patients with the different alkali. Because of the problems of the sodium bicarb and the salt and water retaining effect, a group in the States, they have tried to a polymer which is non-ionic and is non-absorbable, to see whether it can correct the metabolic acidosis without any deleterious effect or not. And it was a randomized controlled trial called Vivaramer, this compound. And they found that after the 12 weeks of the trial, the metabolic acidosis has definitely improved significantly without having the problem of the sodium issue in this group of patients. And of interest, this group and the physical activity has improved significantly in the Vivaramer arm compared to the placebo. And this group now started a multi-center randomized controlled trials around 3,000 patients, one of them in the UK, trying the Vivaramer instead of the sodium bicarbonate, correcting the metabolic acidosis, looking into a hard endpoint, looking into end-stage renal disease and the development of cardiovascular events. Started just only maybe a few months ago. This is the clinical evidence and the intervention of the metabolic acidosis treatment. This is the bone issues we know, all of us. So the correction of the metabolic acidosis is not only improving the progression of the chronic kidney disease based on the evidence that I have introduced, it also improves the bone physiology and the muscle catabolism and the protein catabolism. All of us know that. To conclude, metabolic acidosis is common in CKD stage 4 and 5. It contributes definitely to the progression of CKD on the experimental and the clinical level. Intervention has shown that it has got some value in slowing the progression. And the KDIGO guidelines in 2012 suggested, not recommended, that patients with CKD and have got low bicarb level less than 22 millimole can be treated with oral alkali. They didn't specify what type of oral alkali. Obviously, the only ones that we have got sodium bicarb. There is a potassium bicarb, potassium citrate, which usually we don't use in this patient because of the potassium problem. And the sodium citrate, we don't use it commonly in these patients as well. NICE guidelines in 2014 recommended rather than suggested oral bicarb for EG far less than 30. Upper limit of bicarb is controversial, maybe 26 millimole because of the increased mortality, increased risk of hospitalization, which is still unclear why, and in hemodialysis around 27 millimole per liter. The Viverimer hopefully will give us an answer by 2021 to see that whether the correction of the metabolic acidosis was something different from the sodium bicarbonate, which is the available alkali at the moment, will make any difference in CKD progression and the mortality or not. Thank you.